session. Today we are having Dr. Gayatri taking palliative care on non-cancerous illness. So we will start with ma'am's presentation. We will have the presentation till 3:45, followed by a brief discussion on it. We can start our case presentation by 4 o'clock, followed by its discussion. We can wind up our session by 4:30. So thank you all for joining.
So Dr. Gayatri Pala is a associate professor in MNJ Institute of Oncology, Hyderabad. She has been in palliative care for last at least 25 years, and she was my teacher, and now she's in the board members of IHPC, and she's the director of the World Cancer Association. Welcome, madam, and it's over to you for presentation.
Thank you, Dr. Sunil, for the introduction, and welcome to all the participants who are joining for this session. And I'll start with. I'll request Rajlakshmi to help me with moving the slides whenever I say, yeah. So. Looks like from what I understood, all the participants, they have received all the basic class on class on communication, pain management, and basics of palliative care. So we are taking this session is to take you around to another dimension where because of most of our discussion in all symptoms is based around cancer patients. So let's understand a little more about what happens when we are dealing with non-cancer conditions. Next slide, please. So today's objective of my presentation, the two broad objectives, is to understand why do we need to talk about patients with non-malignant conditions whom we think may benefit by palliative care. First objective, and second objective is to identify how to recognize those patients who are how do we say they are eligible for palliative care? When do they become eligible for palliative care? These are two broad objectives. Next slide, please. I thought I'd start with a case study. Here, I speak about one patient with dementia, an 81-year-old retired teacher. George lives with his wife, Susan. George was diagnosed with dementia 5 years ago, and now is very rapidly deteriorating. You know that dementia is a progressive disease. It is a incurable disease. Very few people fail to understand that it is a progressive and incurable, and often very soon it leads to advanced dementia and death. So here George was very rapidly deteriorating. He was dependent on all aspects of care, incontinent of urine and stool, and he has difficulty in communicating. He was able to walk only a few steps. He needed assistance to walk. He was having a lot of resistance and stiffness for various reasons. Next slide. In the last 1 year, he had been to many doctors, general physician, neurologist, cardiologist, as expected, like in elderly people, we see like so many comorbidities, and you'll end up visiting so many specialists. The last 3 admissions in hospital in last 12 months was for repeated pneumonia. He was aspirating again and again. He was admitted in the hospital repeatedly, and the last admission lasted for 4 weeks. And during that period, his condition became so bad, his respiratory distress was so profound that he was put on ventilator and he died there. Next slide. Next. Yeah. Before he was put on ventilator, and he died there. So this is a very typical case of dementia. And this is how we see a lot of our non-cancer patients, the fate of a lot of our non-cancer patients when they have this disease. If you look at this picture, this is a global picture I taken for India, or it's not my personal view. This is a global as to how do people die. Look at this picture. 66% of deaths that are happening world over is because of non-communicable diseases. Communicable diseases.
Excuse me. There is somebody who is speaking in addition to Dr. Gayatri. Please mute yourself.
Doctor, you can continue.
Madam, please continue.
So if you say non-communicable diseases and injuries, if you put together, they constitute the major cause of death the world over. Next slide. And if you look at the conditions, the various conditions which when we talk about other than infectious diseases, we have the biggest chunk of the condition is coming from cardiovascular diseases. The major chunk of where the palliative care may be required is cardiovascular diseases. Then it is cancer, and there's other sections like the chronic obstructive pulmonary diseases, diabetes mellitus, kidney, liver, dementia. And we also see, if you see, many infectious conditions also slowly, they may require more and more palliative care, like as we see in HIV/AIDS and multi-drug resistant tuberculosis. And often more and more people are talking about chronic malaria, where you may require palliative care. Next slide. It said that there's an epidemic of old and fragile patients with chronic cardiopulmonary diseases. More and more people, congestive heart failure is the commonest cause of emergency hospitalization over 65 years, and chronic obstructive disease, 1 in 20 deaths are from chronic obstructive diseases. So it's a kind of epidemic now, it's happening because people are living with chronic diseases, they're living longer, and they're dying from other causes like heart failure or lung diseases. Next slide. What's happening in India? So this is the global picture. This is what's happening in other parts of the world. Surprisingly, even India is not far behind. This growing, increasing epidemiological transition. Even though we are still struggling with those communicable diseases like diarrheal diseases, tuberculosis, and people are still dying because of that. What we have not realized is this growing burden of non-communicable diseases, in chronic diseases becoming the leading cause of death in rural India. So in villages, actually, people are more and more slowly they're dying of non-communicable diseases. Next slide. This is a very interesting article which came in, which came out from ICMR and Public Health Foundation of India, where they came out with the national level and state level disease burden. What is the level of disease burden? Depending upon which state, there's a huge wide variation. But if you look at it, 48 to 75% of disease burden and disability are because of non-communicable diseases. Just to make a point that how this is becoming the major cause of disease burden today, even in Indian population, all over India. Whichever state you pick, they are becoming the leading cause of disability and death. Next slide. Yeah. Historically, when we talk about palliative care, it all began with cancer. For some reason, it began like that. Maybe in African countries, it began with HIV and AIDS, but traditionally, world over, it is still palliative care means it's mostly originating from big cancer hospitals. But now there's a slow shift in that outlook. Next slide. So why the question is, why do we need palliative care in non-cancer conditions? Let's see what is the disease burden in non-cancer conditions. Next slide. Next slide. Now, this is one study, one major study, which looked at the comparison of symptom prevalence in advanced cancer, AIDS, heart disease, chronic obstructive, pulmonary, and renal diseases. What they did was they looked at the existing evidence about the disease symptom burden among all these conditions. What they found that all of these conditions, all these end stage conditions, pain, breathlessness, and fatigue were found to be in more than 50% of patients. That was the top common symptoms and symptom burden in all of these conditions: pain, breathlessness, and fatigue. Next slide. So they just looked at how the percentage. If you look at it, I just put all major and non-communicable disease conditions. And if you look at the percentage, in fact, some of the disease burden is much more in other conditions than cancer. If you look at dyspnea, see COPD has higher, heart failure has higher dyspnea prevalence. Pain, of course, more in cancer, but fatigue again higher in all, almost similar in all disease conditions. Depression also quite high, anxiety, anorexia. If you see, they all other conditions also have a similar symptom burden profile, just like how we see in cancer. Next slide. Next slide. They also went on to say that when you they looked at the journey of all these disease conditions. Next slide. They showed a common pathway to death for people with all advanced progressive diseases. All of these diseases had a similar common pathway, and palliative care was relevant in all of those conditions, which was needed in all these conditions. This is one study I think which really, after that there were several more studies, but this is one I think we can look at the reference, and it will be good to refer to when you want to talk about non-cancer conditions. Next slide. Now look at dementia. I started off with this Mr. George and his condition. What happens in dementia? Look at the symptoms experienced by advanced dementia. People think dementia means forgetfulness and that's it, and it progresses. No one realizes that they also come with a lot of other issues, physical problems like confusional state becomes sometimes so, patients become so agitated, sometimes they really need high dose of medications to calm them down. Urinary incontinence, pain. Surprisingly, pain is so common in dementia, and that becomes sometimes the reason that all the dementia symptoms get aggravated. Low mood, constipation, and loss of appetite. So many symptoms you see in advanced dementia. Next slide. I said pain is so common, and sufficient evidence that the risk of undiagnosed and undertreated pain in people suffering from dementia is unacceptably high. Nobody recognizes in this whole madness of trying to manage or slow down people with dementia. Nobody recognizes that pain is sometimes so much debilitating to the patient, and they can't even express that they have pain. Next slide. That was about dementia. Look at the heart failure. I'm just picking up common diseases, non-cancer conditions. Heart failure again, 1 in 1,000 population. You see UK population figure. They say they have heart failure, and they say survival rate is worse than breast or prostate cancer in the UK. So breast and prostate cancer, no more they're dying. They rather die of heart failure, not breast or prostate. Next slide. Again, if you can compare the symptom of chronic heart failure and cancer comparison, it's quite high. If you look at the pain, fatigue, breathlessness, insomnia, depression, if you compare, it's as high as you see in cancer, almost. It's similar. Next slide. As I said, dyspnea and pain are the most troublesome symptom, and they are inadequately addressed. So even though we recognize so many symptoms in heart failure, they are not addressed as it should be, even when they are in the hospital. That symptom control is not done well in these population. Next slide. If you look at COPD, patients with COPD scored much higher compared to inoperable lung cancer on activity of daily living, physical, emotional, and social functioning. Compared to cancer, they are much more troubled by shortness of breath. 94% of COPD patients towards end of life, they suffer from shortness of breath compared to cancer, and it is often unaddressed. Next slide. and none of them they receive palliative care services. Next slide. When they compare the two groups, now this is a study which Gore and et al. They studied the two groups, cancer group and COPD group, and they looked at the symptom and how many of them they received palliative care. Also, when they looked at how many of them they wanted comfort care and did not want ventilation, they had a similar proportion. If they had the choice, even COPD patients, they said, I want comfort care and I don't want ventilation. But you know that most COPD patients, end of life is they die on ventilator with this chase to try to control the feeling of breathlessness. Next slide. As I said, they received ventilation. Look at the kidney diseases. We all know that once you're diagnosed with end-stage renal disease, extremely poor quality of life, frequent hospitalization, and the prognosis is very comparable to common malignancies. They all eventually die. It's like just like malignancy. Next slide. And what happens to them? They also suffer from symptoms which are very common. You know that kidney failure patients they develop dyspnea, confusion. They develop a lot of pain syndromes, which is often not addressed to, not recognized. Severe pain conditions they develop, and anxiety and depression, which are very common in all end-stage kidney diseases. Next slide. As one more study which talks about, which came in United States, they have this very good UK renal registry annual report, and one is the US based, and they all repeatedly they have written that patients with advanced CKD suffer from high symptom burden and psychosocial issues and out of pocket expenditure which are catastrophic. I think most of our patients in India, they have a similar or much more profound experience in these areas. Patients who are in dialysis, we think end-stage renal disease means the treatment is dialysis. What happens to patients who are on dialysis? They also suffer from high level of disability and symptom burden, repeated hospitalization, and high level of symptom burden even in patients on dialysis. And most of them they eventually withdraw because they just can't go on with dialysis, and they withdraw, that that leads to death. That is a fact. And in India, the add-on burden is that because of financial reason they withdraw from dialysis and they die, and very poor health-related quality of life. It is a universal world phenomenon. It's not just restricted to our country. Next slide. When they were given the choice that it's a terminal nature, most patients preferred comfort care, and they also never wanted resuscitation when they were asked. But still, there was complete lack of patient preparation for death. Next slide. So the point I want to make here is that most common end-stage conditions which are not cancer, like heart disease, kidney disease, COPDs, they all suffer from this kind of high symptom burden. They all prefer, if given the choice, wanting comfort care and not wanting any aggressive intervention. But none of them they receive palliative care. They all die because of aggressive intervention. So why is this happening? What are the barriers to this? That why people are not aware of palliative care. They are not getting palliative care. What are your thoughts around that? Why do you think there's a barrier? I know that I don't see you directly, but then I put some my own thoughts on why there's so much a barrier to non-cancer palliative care. Cancer itself we are struggling, but non-cancer just doesn't exist. So one of the biggest barrier they say is that the prognostic uncertainty. They say this one very interesting study. A patient with heart failure, the doctors predicted that there will be greater than 50% chance of survival for more than 6 months, but they died 3 days later. So much of wide prognostic uncertainty. Here we are talking about 6 months, 50% chance, and they all died in 3 days later. It's a very bad prognostication actually. So with so much of prognostic uncertainty, what happens in these kind of conditions? Next slide. You must be familiar with this graph. Many of times, I'm sure it's been repeated. What happens in cancer? The diagnosis is made. Initially, they will live considerably well, and they undergo treatment. They may become all right, and sometimes the relapse happens. Once the relapse happens, the sudden decline, and the patient dies. This is the natural curve of how patients with cancer live. Next slide. All the other end stage organ these conditions which you see, whether it's heart failure or lung failure, if you look at this graph, what happens? The decline, there are dips, there are conditions, and the patients become very bad. They get to the hospital, they are treated, they get all right, and they go back home. Again, there's a dip, and they become again sick. They go to the hospital, they get better, and go home. If you see all these dips happening, with each dip, the general condition declines. The performance status overall, there's a gradual decline, and we don't know which dip they will die. That becomes a challenge because
Hello, ma'am. We will wait for a couple of minutes. I think there is some connectivity issue with the doctor.
Just join back.
I'm sorry, Dr. Radhakrishnan, I lost you for a minute.
Yes, ma'am. You can continue, ma'am. I hope you can see you can see your presentation, right?
Hello?
Hello, ma'am. Can you see your presentation?
Hello? Can you?
Ma'am, can you hear us?
Hello, madam.
Hello?
Hello, ma'am.
Hello?
Hello, doctor. Can you hear us?
Sorry, I think I lost you for a minute, for a period.
You can hear us now, doctor.
Yeah, I can hear you. I'm sorry. I'm sorry about that.
Okay, no issues,
It's
doctor. You
little
can continue.
unstable here because of the. Yeah. So
Yes.
as I said, the typical heart, lung, or liver condition, there are dips and this slow decline and then the death. We don't know which dip they may die. So that leads to a lot of uncertainty, and the physician often they don't know when to refer, and that's the one common reason they say that it's very difficult to say when is the time for palliative care. Next slide. What you see in old age related problems, dementia or frailty, it's a gradual decline. Again, there are many small dips, and there's a very fast gradual decline, and then this is what we see in dementia and frailty. Next slide. So from professionals' point of view, what we say, they don't know when to refer. This is known as this paralyzes the doctors, uncertainty, and they potentially that's the reason that prevents them from referring to palliative care. Next slide. And there's another very strong reason, mostly doctors, especially when they're not trained in palliative care and they don't recognize the benefit they may get from palliative care. They think that it's a very natural desire to be optimistic, and they think that they unnecessarily alarm the patients by giving these kind of thoughts about impending death. I remember one neurologist who used to tell me she was very pro palliative care and she used to refer all advanced dementia. So I used to tell her, why don't we start this discussion early on during dementia? She said, no, we can't alarm dementia patients saying that it is a very terminal condition and it may progress. I cannot say that. So that's a very big barrier among doctors when we talk to them about telling these things early on to the patient. Because by the time we see them in advanced dementia, hardly there's any communication happening directly with the patient, and we don't know what's patient's last wishes or what kind of advanced directive patient had about his care. Next slide. On all the bullets. So the other professional barrier is medical perception that is a failure. We think if I can't fix the problem, which happens even in cancer, it's my failure. And then we don't have the skills in symptom control. Imagine a patient with advanced COPD. If the patient develops dyspnea, most physicians, all they know is giving oxygen or putting them on ventilation. They don't know that there are other ways to manage dyspnea and COPD. And of course, even if they think, okay, this patient requires palliative care, they don't have, they don't know where to refer. There are hardly any specialist palliative care resources and evidence. There's no resources, no evidence, and they don't know where to refer also. Next slide. Hospital policy doesn't agree. The hospital doesn't look at all super specialty hospital. Where do you have palliative care? So it doesn't exist in policy, and the services is lacking most places. Next slide. Next slide, please.
Can you see?
Next slide. Yeah, can we just put on all the full bullets? So from patient and family's point of view, the moment we say, suppose you have an end stage yeah, I can see. When I say end stage heart disease or COPDs, the immediate perception is that I don't have cancer.
Madam, Madam, we lost you for a few seconds.
Yeah. Yeah. So I can see you now. Can you hear me? I really regret this flickering thing because of rain. I think the sun challenge today. So forgive me. I apologize for that. From the family's point of view, that I don't have cancer, so don't talk to me like as if I'm going to die. So in that whole process, there is no adequate preparation for end of life care even, and often that leads to life prolongation by any means. That is the problem which we see from patients and families' point of view, because they think only cancer is terminal, other things are not yet terminal. Next slide. So, when to refer to palliative care? How do we, because we talked about so much of prognostic uncertainty, remember those graphs, and like how often we overestimate the prognostication, even the experts, they do it. So that lot of this prognostic uncertainty is the biggest barrier. And so when to refer to palliative care? The recommendation, next slide. The recommendation is that, next slide. There is a very interesting supportive and palliative care indicator tool. I recommend that when you get time, just go online. Hello? you go online and look at this SPICT, SPICT. This is a very nice one-page document which talks to you about when to refer to palliative care and different conditions. If you can see, I don't know if they can read. There's kidney disease, heart disease, respiratory disease, liver disease, cancer, and frailty. For every condition, there's a very nice bullets, very quick reference to, okay, when you have these conditions, refer to palliative care. I'll give you some examples. Next slide. So in this pict, if you are talking about, next slide, heart disease. I just taken that this from SPIC. They say that if you have an New York Heart Association classification 3 and 4 heart failure or extensive untreatable coronary disease with breathlessness, chest pain, or fatigue at minimal exertion, or severe inoperable peripheral vascular disease, refer to palliative care. That is an indication when you have heart or vascular disease. Next slide. Liver disease, they say advanced cirrhosis with one or more of the following complications past 1 year. If you have any of these complications, refer to palliative care. Like diuretic resistant ascites, encephalopathy, hepatorenal syndrome, like that. Bacterial peritonitis or variceal bleed, recurrent variceal bleed. So if you have cirrhosis with any of these conditions, refer to palliative care. Next slide. Kidney disease, they say stage 3 or 4 or 5 with deteriorating health, or if you have other comorbidities, if the patient has stopped dialysis, if the patient has advanced diabetes with other unresponsive to treatment, deteriorating kidney condition, refer to palliative care. So these are the examples like how it is given in SPIC. Just a guideline as to when, which you can follow as a quick reference as to when to refer to palliative care. Next slide. So, as a whole, the big general recommendation is, next slide, when to refer to palliative care. Access to palliative care should be need-based rather than the diagnosis. Whenever the patient needs palliative care, that option should be there from the beginning. Palliative care will help you to live your life better. So whenever you feel you think you need palliative care, ask for it. That is the general recommendation. So it should be need-based. Another thing is, I don't know how many of you are familiar with this, what we call it a surprise question. A strong recommendation offering palliative care to anyone who, in all probability, is likely to die within the next 12 months. Now, how will you know the patient is going to die in next 12 months? Ask the surprise question. Would I be surprised if this patient died in the next 12 months? This is what we call it a surprise question. We use it for all conditions. Cancer, it is very well known, but we use it for all conditions. And usually a very experienced clinician, they are not overtly wrong when they ask this question to themselves.
Madam, are you there? Hello?
Hello?
Yes, madam.
Sorry, I think I lost you in between. So I was referring to that surprise question, which we often use in cancer, but it also applies to other end-stage, all end-stage conditions. That am I surprised if this patient lives for another 12 months? If you think he's not going to live for another 12 months, can we go back? Go back? Yeah. Then if in all likelihood is not going to live for another 12 months, that patient should have this opportunity, have the offer to have palliative care. That is the general recommendation for all end stage conditions. Next slide. So to conclude, they say that skills like, we know that we don't have enough resources, there are not enough palliative care services available. And so where do they refer? So what the general recommendation when you're dealing with non-cancer conditions is that all health workers who are working in various specialty like cardiology, nephrology, or liver, gastroenterology, all health workers should have training in skills like symptom control, difficult conversations such as sharing bad news, prognosis, addressing uncertainty, transition to end of life care. These are the topics which they should all undergo training while they are undergoing their specialty training. And there should be a way to, if even if you don't have a dedicated service in your hospital, if you can liaise with some other palliative care team or integrate with them early on, I think there's a better chance that patient will be benefited. This is the one two important recommendation or recommendation is given the world over. Next slide. And finally, we don't have enough evidence because these are all very Western evidence. Suppose we are talking about India and non-cancer palliative care. I think we have to start with very basics. We have to start with our own need assessment in various conditions. What is the need assessment? What is the evidence that these people are having high symptom burden? If you have good statistics, I think we can go to these forums and have a conversation about the need for palliative care. So I stop here. I really apologize for these interruptions, but I am ready to take questions.
So thank you, madam, for that general overview about chronic, about non-cancer illness requiring palliative care, and also for the recommendations when to refer the patients to palliative care. So the session is open for discussion. I know most of you are working in cancer hospitals, and there are many oncologists also. So, if anybody has any questions, please come. Dr. Gavra? Dr. Gavra, please unmute yours. Yeah, we have
Yes,
one.
my question to ma'am is like the new MBBS curriculum has recently been introduced, and I think there is a provision where they teach orient the patient, the students to some sort of palliative medicine. So now we are talking about this change which has come only in 2019, and to see the eventual effect of this in the community, in the practicing physicians, it will take at least another decade. So initially, when we started with this course, we were focused on oncologists as well as non-oncologists. And what ma'am has presented today, it emphatically proves, it shows that even the general physicians, neurologists, cardiologists, all specialties need to be oriented. The problem is that now at this moment, we have got a huge, more than 90%, 95%, 99% who will not agree with putting patients on palliative care. So I think their orientation is much more important, because right now if we need to make some sort of any sort of benefit for the patients who are CHF or CKD patients, so how does ma'am propose, like, because people are actually busy with the services, with the jobs, with the practices, how does ma'am propose that these non-oncologists would be trained for taking care of the palliative needs or referral to palliative care services?
I think it's an excellent question. I totally agree with you. The new MBBS curriculum, it's only for the undergraduates and it's for the next generation doctors. Now we are talking about the existing practicing specialists in various areas. Basically, we had renal medicine, all the national level, very well-known renal medicine specialists all came together, and we few of our palliative care people. It was meeting about conservative management in renal end-stage renal. And there, that was a forum where we came out with one very good consensus statement about integrating palliative care early on in renal diseases. And now we are going to publish a kind of a consensus statement on this, both in the renal Medicine Journal and as well as Indian Association of Palliative Care Journal. I think if we have more and more of such kind of forums where we come together, talk about this, and make them realize the international guidelines and consensus, and bring out our own national guidelines. That's the only way we can make them even think about palliative care. That's our difference. And yeah, that's the only way right now we can do immediately to bring that change. And having, of course, more and more palliative care services available. So many of you now, I see around 18 people are joined. I'm sure all of you, when you go back and start palliative care service in your own centers, there's more facilities coming up. So there'll be more confidence of people referring patients to you. I think that's how we're going to start. I totally agree. There's hardly anything existing for non-cancer palliative care in India currently.
But
Yes, Dr. Gaurav.
Dr. Gaurav.
You are not audible.
hello, am I?
Yes, now.
Ma'am, but the real problem is, like, as you told us, that neurologist would only send the patients to you when probably she knew that this patient is going to deteriorate within the coming few weeks, instead of starting very early. How do we convince people with people who are taking care of COPD, CKD, and chronic heart failure patients to send the patients early on for better symptom management? How do we do that?
Absolutely. So it's very difficult, especially the doctors who are trained in India. What I've seen, even in oncology, the doctors who are trained in India, they have very limited outlook about the approach, the palliative care approach in their practice. So either they go abroad and they have that exposure. In India, the only way we can bring change is that very important, their own bodies coming out with this kind of strong statement, their conferences, in their workshops, talking about it. It has to be from them. We can only suggest and show them international guidelines, and making their own body to talk about this, the only way I think we can do it right now. I think I lost you. Can you hear me?
Yes, madam, we can hear you.
But Sunil, can you?
Yes, madam.
I think we have to get involved, get infiltrate into their national bodies. Like what we're trying in pediatrics. I didn't discuss anything about pediatrics. Pediatrics, I think the cancer group is very small. The pediatric palliative care is mostly major chunk is for non-cancer. The only way we can influence pediatricians is by getting into their national bodies, getting into their meetings, and make them talk about it, and have some kind of declaration brought by them. Then that's the only way we can influence change, I think. But that's my viewpoint. Anything, Sunil, you want to add? Do you think trying?
Yeah, I think what you have told are very important, which we have already done in some occasions. But to add to that, I would also recommend that the awareness of the community should be more. As of now, it is not only with the medical professionals, but also there is a problem in the community. So community also thinks that palliative care is mostly for cancer patients. So that has to be changed. So the community needs more awareness on palliative care and what are the types of diseases that can be cared in palliative care. So if the community also raises some voice to the treating physicians, then that will also add on to what Dr. Gayatri already told.
क्या दिखा?
मैंने क्रिस्टीन बिरलोन के नाम से एमजी में शो कर रहा है।
ओ, यहाँ पे एम नहीं, सॉरी,
एमजी में है,
ये एमजी होगा, ये में 1 मिलीग्राम।
Okay. Madam, do you agree with what I have told you? Hello, madam. We lost Dr. Gayatri. But I would also like to talk regarding non-cancer illness in pediatric age group. We have pediatric palliative care mostly in cancer patients, but when we started a pediatric palliative care for non-cancer patients, that was started in a medical college, and actually it didn't go well because there were no cooperation. But once the Indian Academy of Pediatrics and that also got involved, then there was a momentum in the non-cancer pediatric palliative care. So what Dr. Gayatri recommended is very true. Anybody else? Dr. Patma?
Dr. Patma, you wish to add something?
Told about MBBS curriculum. No, in the forthcoming year, that is in 2020, I think we have to be geared up for this subject separately so that they will be trained at the level of primary care physician itself.
Okay, thank you. Dr. Abhishek?
Yes, sir. Actually, this is excellent opportunity for learning this palliative care for non-communicable disease, and I think training a family physician would be a best way to deal with. Like lots of cases, apart from cancer, are dealt with family physician. So training up a family physician will go a long way for this kind of palliative care to non-cancerous palliative care for all other diseases. Thank you.
Thank you. Anshika?
Good afternoon, everybody. Sorry I joined late. Am I audible today?
Yes, yes, you are.
Okay. So I'm sorry I missed major part of the presentation, although I tried to log in the beginning also. So palliative care for non-cancer, we of course identify that. It has to be, in fact, last year in our CME in the medical college, I presented the topic palliative care for all. So this CME is for all the faculty and the PG students of my medical college. It happens on every Saturday morning, 8 to 9. So when my turn, palliative care department turn came, so I presented the topic of palliative care for all. So for all, we emphasized it's not just for oncology or my CRI department. It is for everybody, every single physician, every single postgraduate needs to know the basic of palliative care and how it applies to their, for example, chronic renal failure, cord injury. Even neurosurgeons need to know palliative care, for example. And in fact, after that, in our college, they have come up with a multidisciplinary neurosciences building where they have included the physiotherapist, occupation therapist, the pain management team, and they are looking at the palliative care issues separately in neurological patients. So I'm very happy that, at least in our college, they have adopted palliative care for all.
Okay, thank you. That's very good.
Dr. Anshika, where is this? Sorry, where is your college? I missed the introduction part of it.
Ma'am, I'm working at CRI Dehradun. It's in Uttarakhand.
Okay.
It's a Himalayan Institute Medical College.
Oh, wow. Okay. I've been to that place. Yeah. It's a nice facility. Congratulations.
Thank you, ma'am.
Anybody else has any comments or questions? If you have any questions,
I think
madam, there is a question from here.
It was mentioned in the presentation that the conclusion part that it would be a surprise if the patient survives next 12 months. Can you explain it in detail? I didn't get the point actually.
okay. So when you see a patient, so let's talk from cancer point of view. That's most easy to understand probably because most of us are so heavy.
Madam, you are not audible. Madam? Okay. So let me try to answer that question. So when you see a patient and you are asking yourself that would you be surprised if this patient will be there for next 12 months? If the answer is no, then that means that patient is fit to refer for palliative care. So this is applicable for any type of patients. Usually, this is by, I think it is developed by NHS, and they're using that surprise question.
So I have one more question
Yes.
to the faculty. So do we have some sort of palliative care principles for people in jail who are on death penalty, death roll? In should I repeat the question?
Yes, yes.
Sir, in India, do we have palliative care principles followed in the jail for prisoners who are on death roll, like we have in other developed countries? Are you aware of anything
As far as I know, there
like that?
are no. I don't think Anshika. But there are some people from some medical professionals in some jails who are trained in palliative care, but not much.
Okay, sir. Thank you.
So let me try to summarize this session. Uh, Okay. So it's important that we should give palliative care for non-cancer illness because the symptom burden, if you look at the cancer as well as non-cancer illness, both are almost same. And it has seen that pain, breathlessness, fatigue, these are most common symptoms in non-cancer illness also. Not only from the physical problem, but also they suffer from other problems like psychological, social, spiritual, financial problems. So all the non-cancer patients will fit for palliative care. And I don't know whether you remember that Dr. Rajagopal told you that palliative care should be applicable for any patients with serious health-related suffering. Okay. And Dr. Gayatri explained the symptom burden in congestive cardiac failure, COPD, and dementia, and many of those non-cancer illness. And there are some criteria by which you can refer the patient to palliative care in non-cancer illness. SPICT is one, and other one is the surprise question. But as a general rule, any serious health-related. So, madam, shall we move on to the patient story?
Yes, please. I'm sorry, like I'm missing out on most of the conversation. Please carry on.
Yeah.
So over to you, Dr. Mohan. So can you unmute yourself? Yes, sir, you can speak.
Yes. Good evening to all.
Good evening, sir.
I'm sorry I'm not able to join in time. Still, we are having power failure. I'm using the cell phone. The power available with the cell phone also very limited, so rush to the slides. I'm thankful to the institutions and the organizers for giving the chance. I'm going to present a case of, next slide please. Next. Yes. A 75-year-old male, the history of not able to use both legs, diagnosed as a paraplegia due to the parts disease. Next slide. Presenting complaint was inability to use both the lower limb with retention of urine, some psychological problems. Next slide. 40 days back, the patient was apparently all right, developed weakness in using the both the lower limbs. So was managed by himself in the family, followed by complete inability to use both the lower limbs and retention of urine, for which rushed to the medical college hospitals, admitted in the Trichy Medical College in Tamil Nadu. Not in known case of hypertensive, diabetic, or renal disease, or any TB cases. No history of trauma or hello.
Yes, please
Hello.
continue. Please
Routine
continue.
investigations including routine investigation including X-ray and complete blood exam count didn't show any significant changes. MRI shows bony compression, which neurologists suggest it is a parts compression leading to the paraplegia and retention of the urine. Next slide. Next, please. So on examination, patient was conscious, oriented, response to command, vitals are stable, all other systems are normal except bladder extended. Local examinations, tone, upper limbs, both the right and left are normal. Lower limbs, tone was decreased in both the lower limbs. Power was in the upper limb normal, lower limb 0/5, 0.5 both the limbs. Plantar extensor, sensory system was normal. Next slide, please. Next, yes. The investigations are these are the investigations carried out except the MRI. All other investigations are normal. Not in open diabetic or hypertensive or TB. X-ray also normal findings. HIV also active. Next slide, please. Next. Next slide. Yes. Psychological aspect. Worried that he'll never be cured. Have to depend on others for day-to-day activities. Was agitated. Despite more than a month since admission. No improvement according to them, but developed bed sore within a short span of 20 days of staying in the hospitals. Refused adequate oral intake. Poor sleep. No family support since he was left with the wife. She is also old age, not able to support him in day-to-day activities. Afraid if surgery could be beneficial for him. Being admitted in the government medical college, no cost of implementations for the treatment for the other day-to-day expenditure. They are supposed to depend on others, but is not supported by the other family members, including their sons and daughters. 3 children all settled but neglected him. Is to go home to die. Next. So these are the treatment given. Only all asymptomatic except the physiotherapy and anti-TT just started. Planning for decompression surgery by the neurosurgeon. Next. Next slide. Main concern is inability to use both the lower limb and the retention of urine. Within 20 days of stay in the hospital, developed a bed sore. Feeling of hopelessness. No complaints with the further management. Irritability, anger due to inability to take care for himself, not able to pass urine. Wife feels difficult to manage and home without the support of the children. In summary, bilateral paraplegia due to the part spine. I also suspect CKD, but there was no supportive findings. Symptomatic treatment only started. ATD just started. Plan for decompression surgery. This is also already started. Bed sores within a short period of 20 days. Poor care given by the family members. psychologist issues causing hindrance for the management and adequate care at home. Next slide. Next, discussion points. The main concern is their inability to use the lower limb and retention of urine. Within 20 days of stay in the hospital, develop better. So, as a beginner in a palliative care, can you include this case for a palliative care or after the completion of the treatable causes? If so, what type of care can we start at this stage? Can we start psychological intervention in this case at this stage level? So what other services will help him to improve the quality of life? Why feels best effort medical management not helping him? Family members except wife neglected him because of the poor socioeconomic status in the family. After discharge, how they are going to manage him in the at home? Need to have home-based counseling if the healthcare facilities are not provided by the government sector. In our state, we don't have any palliative care available at all the primary health centers. They started palliative care services in the block PHA alone. Thank you.
Dr. Mohan. This patient who has port spine and he has developed paraplegia. The problems are he's paraplegic with retention of urine and he has pressure sores.
Hello.
Can you hear?
Hello.
Can you hear?
Hello. So not able to hear, sir. Hello.
Yes. Hello.
Hello. Yes, audible, sir.
You can hear us?
Hello. It's interruption in the so much disturbance, sir.
Can anybody hear us?
Yeah, hello.
Hello.
Yeah,
Hello.
we are audible, isn't it?
Yeah, you.
Hello.
I can hear.
Okay, I think Dr. Mohan is unable to hear us.
Yeah, I can hear.
You can hear us.
Hello.
Yeah, we can hear you. So his problems are he's having paraplegia. He has pressure sores. Then he has psychological problems because only wife is taking care of, even though he has 3 children. And how are they going to manage after they are getting discharged from the hospital? Yeah. So these are the concerns that you have raised. So the first question is, can we include this patient for palliative care as of now or after the completion of treatable course? So I think any of you can answer this question. Somebody please answer this question for Dr. Mohan.
Yes, Dr. Mohan sir, it's yes, we have to include this patient.
And Shiga,
please louder, please.
Yeah.
I think we have to include this patient under palliative care support. And even if we may not call it palliative care, at least we can call it supportive care. This is the patient who needs palliative care. So answer is yes.
Yeah. Anybody else want to add any more points to that?
I think Sunil, can I make a comment here?
Yes, madam.
Yeah, so in response to whether this patient is eligible for palliative care, we have extensive community-based program in Telangana, government-led program, where we have palliative care approach in the most remote villages also. where we do survey, identify patients, and then we take care of them for palliative care.
Madam, you are not audible now. Hello, madam.
Elderly people following for
Madam, we lost you for a couple of minutes. We haven't had you. You were talking about Telangana, and thereafter we didn't hear anything.
Yeah, so in Telangana, we have a government-led community-based palliative care program in major districts, and one significant population whom we identified who required palliative care in the community are people with history of fall, becoming bedbound, developing complications following that, requiring palliative care. Especially elderly, fall leads to rapid reconditioning and they become bedbound and they die because of various complications. So it's a very important eligibility for palliative care, a fall following which they become bedbound. So it is definitely a candidate for palliative care. There's no doubt about it.
Okay. Dr. Mohan, so palliative care can be started early in the course of illness as per WHO definition. So we need not wait for the
So much
completion of.
interruptions are not.
Sorry?
It's not audible, sir. So much disturbance.
Is there any disturbance from our side? Somebody please answer. Next.
No, sir, it's clear actually. We are able to hear everything.
So, Dr. Mohan, most probably it's the problem from your side.
Okay. Now it is audible, sir.
Okay. So, palliative care can be started from the early course of illness as per WHO definition. So, you need not wait for whether it is you can start palliative care after completion of treatable causes. You can straight away start whatever the yeah. So that was the next question. If so, what type of care can we start at this stage? So somebody please come up with some suggestions. What type of care can we start at this stage?
The patient has developed bed sores in the course of the disease. So we might actually we should begin with the education of the patient and carers, both of them, regarding the disease condition and the prognosis. Of course, the disease is treatable, but meanwhile, whatever morbidities the patient develop, like the bed sores and all, they should be taught to taken care of those things like change in position, cleaning the wound and dressing and everything, and then physiotherapy if needed.
So Dr. Anshika?
I think Dr. Mohan has done quite a good meticulous palliative care assessment of this patient. I think he has told us about physical problems, psychosocial problems, family problems, and probably I think he in brief mentioned the spiritual problems as well. So taking each point, as somebody mentioned just now, the physical issues, of course, the bed sore care and other things. We have to take care of psychosocial as well as social issues in this patient. We need to empower somebody in the family so that the patient eventually, when they go home, they can be taken care by their own family member. And we have to identify that family member and empower her, probably the wife, with all the knowledge and information and also practice of caring for this patient.
Okay, thank you, Anshika. Anybody else? Madam?
Hello.
Yeah, Dr. Abhishek.
Yeah, I'm fully agree with Dr. Anshika. Home-based care with proper training of their caregivers, along with physiotherapists and palliative care physician will help in this case. But care should be at home-based.
Okay. Gayatri, madam?
Yeah, from what it's very interesting and very interesting case, very comprehensive assessment and management approach. And I really was impressed by comments by all the participants. While the patient is in the hospital, ideally, like suppose I see a patient in this kind of circumstances in the hospital, before the patient gets discharged, we should have a proper care plan for this patient. Care plan in the sense what kind of physical care or the rehabilitation care we are planning, what kind of care coordination, like where the patient is going to go, who is going to take care of the patient, what kind of support system they'll have in the community. And the care plan is also about how to take care of the caregiver, because the spouse very frail and she's just not capable of taking care of the patient. Caring the carer is another big important aspect. And most important end of everything is that having some kind of crisis plan when they're getting home away into the community. Suppose they develop some complication, where will they refer to, where will they go to, whom do they call? That makes it complete, having some kind of a crisis plan in place. First of all, anticipating what kind of crisis this patient will develop in the home setting. And suppose they develop this, what is that in things which we can do immediately in the home, and where will they seek help in the event of crisis? And that should be a kind of a very comprehensive care plan which we can have for this patient. Yeah, that's how I would approach this patient care.
Okay, thank you, madam. So, I think one of the problems within the family was there are three children who is not looking after the parents. So I think if you have some social worker or somebody in your team, I think it will be important to call a family meeting, get also these three children and explain to them what has happened and how to go forward. So that there will be some support for the family, for the patient and also for the wife. So madam just now told that it is important to care for the caregiver also. So these three children has to be there in the meeting, family meeting, and we have to make a plan. So what are the other services that will help him to improve the quality of life? Anybody?
So to improve quality of life, I think the first thing we have to do is find out from the patient and the wife what according to them will improve their quality of life. Once we understand their hopes and desires from the treatment, we can come up with a solution for the same, or more of counseling and trying to get to reach that level. So we have to discuss more with the patient and the family to be able to answer this question.
Yes, exactly, Dr. Anshika. So quality of life is decided by the patient or the person who is suffering. So we have to talk to them and find out what are the important problems as of now for them, and we have to find out some solution, or we have to facilitate how to take care of that problems.
I think one more thing which we can think about when we see this kind of dysfunctional family, palliative care, the team plays very critical role in bringing the family member together. We don't know why the family is so dysfunctional. They are not taking care of the patient. We don't know. We really need to explore, find out, and what's something what we call it as family.
Economically, they are very poor, ma. Economically, they are very poor. They have to depend on the 100 days work.
Absolutely.
Mahatma Gandhi.
Absolutely. So maybe that
That's
one
why they
day,
are not.
staying back will take away their daily wages. But still, it will be worth understanding. A lot of things we should not. One thing we learned in palliative care is not to make assumptions, like as to why they don't take care of them. So maybe you have already explored that, but something for the other learners, I'm saying, I would always say that let's call the family members together and have a family conference, talk to them and find out and acknowledge the problem. Do you realize that your father is now totally bedbound? Your mother is not capable of taking care of him and he needs care. We don't know how much time he has left with him, but the remaining time he needs really care. Is can we understand better as to why this is not happening, or what are your concerns? So this kind of family conference sometimes bring out something very significant, which we may be able to change in their behavior or something. We don't know yet. But as you, doctor, you said, maybe already explored and found out that for them that one day wages is very critical. So yeah, that's important to understand that. So the family conferencing is very important part of whole planning.
So the wife feels that despite best effort, medical management is not helping him. So Dr. Mohan, is it because he is still paraplegic? She is feeling that medical management is not helping him.
Yes, still he is having problems.
Okay.
She's also old age, very difficult to manage him. That's why the doctors complain that that's what due to the non-support of the carers. That is the reason for the. Hello.
Yes.
So obviously there's an increasing bed sore, and the wife feels that nothing is going all right. He's not walking, and now look at this new bed sore developing. What could be one important reason for such ever increasing bed sore for this patient? High risk. What are high risk reasons that he's developing bed sore?
What are the risk factors for developing pressure sore in this patient?
What are the risk factor in this patient for developing
the pressure?
Bed sore. Hello.
Hello. Hello.
Yes.
Hello.
We can hear you, doctor.
Hello.
Dr. Mohan, we can hear you.
Sir, yes, we can hear you.
But so mainly doctors complain because of the non-support given by the carers. Only wife is supporting him. He's also not able to help the patient to turn. The hospital is also not having any latest bed, so that's why the.
Yeah. So probably from what I understood, sir, patient developed bed sore because the wife was too frail to turn him around, and
So weight is
as we
just
say,
50 pounds. It's very thin.
Yeah. So that's the usual typical. That is a classic situation: heavy patient and frail caregiver, and you expect them to provide that care, which doesn't happen, and patient develop bed sore. Another one important reason why they develop bed sore, I think, is urinary and bowel incontinence. Both urine and stool are highly irritant. For urinary, maybe we can reduce the wife's burden by maybe catheterization if the patient agrees. I don't know, indwelling or intermittent is again troublesome for the wife.
It's already catheterized.
Yeah. So, but what about bowel care? That's something we often miss. What kind of bowel care can we give to minimize this incontinence? Because these kind of patients, when they're bedbound, they become highly constipated, and after a few days, they start having leaking of stools, little, and that becomes the reason for bed sore. So, is there any strategy to minimize that kind of repeated history of constipation followed by spurious diarrhea.
Madam, you can suggest.
Tries so that take care of urine not being incontinent. But the patient
Brimafin liquid was given periodically according to the.
Yeah. Okay. Yeah, but then
Manual
still.
evacuations was done for sometimes. Now he's getting Brimafin.
Okay, so you are giving laxative. That is one way to solve the problem. By good use of laxatives, patient will have a good bowel movement. But this is something we can do as an intervention to minimize that chance of constipation and to reduce the chance of leakage, which often happens in bed-bound patients.
Yes, you're correct, ma'am.
Okay, so I think the another question was after the discharge, how they are going to manage him at home, which I think Dr. Gayatri has already explained that we need to have a care plan for this patient, including the care plan for crisis situation. And as this patient is bedridden, already developed pressure sores, then we need to empower somebody in the family with how to take care of skin. Uh, then for the mobility, how to improve the mobility with the physiotherapy and things like that has to be taught to the caregiver. Madam, do you have anything more to add in this patient story?
No, I think it is very comprehensively covered, all the aspects. Very classic example of managing a non-cancer situation. All the principles of palliative care applies here, even though it's non-cancer.
Okay, so in this patient story was apt for today's session because this patient is having paraplegia due to tuberculosis, and it correctly fit into this. So this patient has all the problems like physical problems, psychological problems, psychological and social problems, and financial problems. So which we need to address in palliative care. So to summarize this patient story, so this patient can be included in palliative care as of now because palliative care can be given in the early course of illness as per WHO definition, and he is suffering from serious health-related suffering. So and we can give input in physical aspect, taking care of pressure sores, how to do physiotherapy, and the family members, we can call for a family conference so that we can understand the dynamics within the family, and that will allow the family to most probably there will be some solution for the problem within the family. So the children will also be helpful for the patient and his wife. And we need to have a care plan for this patient so that once they are discharged from the hospital, they can manage the patient at home, and there should be some plan for crisis situation also. So I think we can close the session today. Thank you, Dr. Gayatri, for joining us today and for presenting this, presenting on non-cancer illness. Thank you, Dr. Mohan, for presenting this patient story, and thank you all for joining us and for this interactive session.
I have shared the feedback link. So please do give your valuable feedback. So we will see you on next Wednesday with a topic
Thank
gastrointestinal
you.
taken by Baburaj sir. So see you all next Wednesday.
Thank you.
Thank you, sir.